Thank you, everyone. So this is again one of the most controversial topics. So patient selection will depend on whether you believe in uni or you don't, whether the patient convinces or not, and whether you have enough experience to offer it to patient or not. UKA success is 80% patient selection and 20% surgical technique. Even a perfectly done surgery in a badly selected patient can give a catastrophic outcome. As we know, the traditional indications is most important is anteromedial osteoarthritis. The typical wear pattern when the ligaments are intact damage only the anterior part of the knee and the retained surfaces are functionally normal. The other indications are the spontaneous osteonecrosis of the knee, which involves only one side mostly, and isolated lateral compartment osteoarthritis. The evolution of patient selection criteria has been since 1990s. The historical classic criteria which suggest that isolated medial compartment osteoarthritis should have no lateral joint line tenderness, should have intact ACL, it should be a non-inflammatory arthropathy, the correctable varus should be less than 5 degree, weight should be less than 82, age should be more than 60, flexion contracture should be less than 5 degree, and range of motion should be 90. If we go with these criteria, only 5% of the patient in the population 5 to 6% patient can be offered the surgery. So these criteria were too restrictive, excluded many suitable patients, did not consider functional stability, ignored many modern implant designs. With this, Oxford came up with the criteria which focus mainly on the pathoanatomy of the patient instead of demographic profile. And it required bone-on-bone arthritis, correctable deformity, and functionally stable knee to offer uni. With these criteria, at least half of the patient could be offered this surgery. What are these criteria? So there are clinical and radiological criteria. Clinically, the patient should have medial sided joint pain. Localization is not a reliable sign. Pain may be anterior, posterior, or lateral. Pain on weight bearing is important, usually absent when sitting or lying down, although sometimes night pain can happen. On examination, you have a varus of less than 5 degree, not more than 15 degree. Correctable varus, flexion deformity not less than 15 degrees, flexion up to 110 degrees, and ACL should be functionally intact. So in X-rays, you do standing weight-bearing X-rays and varus valgus X-rays. So first criteria is medial bone-on-bone arthritis. So if you see these kind of X-rays, the above 3 X-rays show good amount of medial bone-on-bone. But in the lower X-rays, if even a partial cartilage is left over, it will not give an adequate outcome. So no bone-on-bone, no UKA. The functionally intact ACL, normally the erosion happens anteriorly or centrally, but never posterior-medially. If there is a posterior erosion, then again not a candidate for UKA. And there has to be a full thickness cartilage preservation on the lateral side, so which again you confirm during the surgery that there is a pristine lateral cartilage which is present. So on a valgus stress view, we should have a good amount of lateral gap which is present. The MCL should be functionally normal and it should be a correctable intra-articular deformity. So repeat X-rays with a stress view if the joint lines are not parallel. So not correctable means that there is no medial opening, then again MCL tightness is there, then it's not a good case to do a UKA. And acceptable patellofemoral joint in a skyline view. If there is a normal or medial facet osteoarthritis with or without bone loss or lateral facet osteoarthritis without bone loss, then you can still offer UKA. But if there is a bone loss and lateral fraying like in the fourth X-ray, then you should avoid UKA. What is the modern understanding? Now these are the factors which are no longer considered as contraindication, which were previously considered. So there is no strict age limit as such. Activity level also can be monitored. BMI is a relative contraindication. Patellofemoral joint arthritis, you can select the patient based on the clinical symptoms. And ACL deficiency, again case dependent. So borderline cases, you need to do individualized decision making. So I'll just brief about young patients. You need to have a truly unicompartmental disease. They should be highly motivated and understand revision possibility in future. Advantages are faster recovery and better kinematics. In obesity, it's technically difficult, so maybe in the early phase, in the learning phase, you should be avoiding, but with your experience, you can offer this to patients. What influence outcome is the proper alignment, surgical technique, and ligament integrity. In patellofemoral arthritis, it is hypothesized that the alignment restoration, improved kinematics, and better patellar tracking is because of improved the patellofemoral congruence. So again, with patients, as shown in the X-rays before, you can still, without bone loss, if there is a patellar facet arthritis, still you can offer this, and pain is reduced with the surgery. In ACL deficiently, the modern understanding is that functional stability matters more than anatomical ACL. So if patient has no instability symptoms, a low demand patient, or an degenerative ACL, which is a non-traumatic ACL, we can still offer this surgery. You should avoiding it in young, active, and patient with instability. Surgical tip, you need to reduce the tibial slope if you want to do it. These are the two landmark studies based on which the current philosophies are based. The one was by Hamilton, which was published in 2016, and other one was Vanderlist et al., published in 2017. Both the studies confirm that with all the indications, if UKR is offered, the outcomes are favorable. Lastly, patient optimization is important, and obesity more than 40 is considered a contraindication. If there is an intra-articular injection patient has received, they need to delay the surgery for at least 3 months. There are 4 absolute contraindications when there is no for UKA. One is active sepsis, severe uncontrolled RA, non-functional or ruptured ligament, and fixed flexural deformity or varus deformity. This is the UKA patient selection flow chart. If it follows all this, then with the right patient, right implant, and right surgical technique, we can give the best possible outcome. I'm just showing us ideal case. This is a pre-op X-ray, post-op X-ray, and this is the recovery that you can expect in a patient of UKA post-surgery. Thank you so much.